There's this sort of myth that you can't do anything about eggs, and I don't personally believe that. So when a patient comes into the clinic, sometimes they come on their own, sometimes their relationship is unclear when they first sit down in front of me. We have individuals on their own who are in relationships and haven't brought the male partner. That's a very classic example where everyone assumes fertility is purely female problems starting right at the beginning there, and actually there's a male side to it, which we both know. So I think looking at the couple in front of you, if it is a couple, and thinking very carefully about their medical history, because everybody's story is unique. It's very much the background and the context to why they're in front of you, which will determine what we'll be looking at. From a female point of view, gynecological history, menstrual cycle history, any pelvic surgery they may have had, infections, difficulty with fertility perhaps in previous relationships or across their lifetime. I'm really just trying to understand a whole sort of overview of their reproductive years to that point. Now, for some people, they're coming to see me, they haven't actually tried to conceive at all, and they're purely coming for information. But some people are coming having undertaken multiple cycles, often sometimes in different clinics, which haven't worked, and then they're looking to really, there's a lot of information to get through. But I think it's really important that we don't forget the male side of fertility, and I know that you are absolutely on the same page with me on this. I think it's a really partly forgotten part of what we do. ICSI is the part of what you do where they inject a sperm into the egg. That sort of cured a lot of problems for male factor issues, and so all of a sudden male fertility, I think, kind of, we began to rest on our laurels. But I think you and I both know that by getting the male factor fertility right, you can improve people's success and outcomes in the lab.
Absolutely, and I think it's really important to note from obviously the all doctors' perspective that one semen analysis or even two semen analysis doesn't give you the inherent diagnosis of a male's fertility potential. And I think a lot of what you unpick in the consultation is potentially any underlying issues. So tell me, if you're sat in front of a couple that aren't actually naturally trying to conceive, what's your advice to them? What would you say to them in regards to going away and trying to conceive? How long would they be doing that for? What would your advice be before they get back in front of you?
So there's a lot of misconceptions around when to try in a cycle. Should you be having regular intercourse? Should you just try in exactly the ovulation window? How long should a man abstain from intercourse before you're actually trying? So there's lots of things that are really important, which I always include, the very basics of making sure that you're giving yourselves as a couple the best chance of success. I think when I'm looking at a couple that aren't trying at all, we would expect most people to be probably conceiving within 6 to 9 months. When I say most, that's not 100%, but certainly more than 60 to 70% of people. And I always give that to people as a rough sort of barometer, so that when they go away and they think 6 to 9 months down the line, okay, it hasn't happened. It's not that you need to necessarily suddenly start doing IVF treatments, but you do need to be thinking, is there something going on here? So having quite a high radar for those issues, so that you come and see a specialist early to talk about it. But really, when we're looking at their history, their medical history is absolutely key. And quite a lot of what we deal with is subfertility problems, but you've got to remember the couple coming to see you are not necessarily infertile. And what we have to explain is obviously their results, their egg reserve, things like the menstrual cycle, how regular it is, are they ovulating, are the hormones that we're testing showing everything to be within the normal range, is the sperm normal, is there any issues around erectile dysfunction, any other medical conditions or diseases, autoimmune conditions, chronic illnesses that can impact on your ability to conceive, and then trying to give them the tools to be able to go away and know how long to try for, what to look for, so that they know that if they do fall into that group of people who are approaching a year of not getting pregnant, they're already prepared with what to do.
And out of interest, what age would you not give that advice to? Or how old is too old for a female to potentially be going away for 6 to 9 months and trying naturally? Where would you change that opinion?
So it's a really interesting question, that. I mean, I get that a lot, because you get a patient in front of you who's 44 who has never tried to conceive, with a very low egg reserve, and perhaps a partner who has normal semen parameters. I think you've got to have an honest and open dialogue with the patient, because you and I both know that IVF does not solve everybody's problems immediately. And so when you are trying to conceive, it will either result in a positive pregnancy test or not at the end of the month. When you put eggs and sperm through the laboratory, through the time-lapse photography, and through all the sort of processes that you will go through with patients looking at genetic screening of embryos, you learn an awful lot about eggs and sperm in that process. Whereas to me, I can't tell the patient any more than Did you get a positive pregnancy test in the month? Was your progesterone in the right sort of levels? Were your hormones in the right sort of area for natural conception to be possible? But if patients are towards the end of their fertile life, certainly from 42 onwards, I would be saying to them, if you haven't tried at all, perhaps begin to try, but don't unduly delay thinking about things like treatments and being proactive, because if someone has a very good egg reserve at 42, there's absolutely a good chance that we may find normal embryos, which will give them a lead on to a pregnancy. But if you think about the number of eggs that become abnormal, increasing in the rate of abnormalities as you get older, and that's not saying chromosomal abnormalities that lead to necessarily problems, but lead most of the time to miscarriage or implantation not working, that accelerates from the age of 38. So those patients really just need to know that actually they may conceive naturally, but if they don't leave it 2 years, because that makes our jobs much harder. So this is where conventional advice, nice guidance, and when patients should stop trying naturally and start things like IVF don't really apply, and you're into a much more of a grey zone here where you have to kind of look at the individuals. I think it's really important to consider the female patient when they are in front of you. Just because somebody is young with a good egg reserve, it doesn't always mean everything's absolutely right. We see patients who have a very subtle history of many years of pelvic pain, and actually that patient has underlying endometriosis that's never been picked up. We may see some of that with ultrasound. Some patients have, for the first time, large cysts on the ovaries that are picked up. There may be pathology in the uterus, pathology being conditions, problems such as polyps, fibroids, and some people come to us and we're the very first people to pick up an anomaly in the way the uterus is formed, and all these things can make it very hard for that patient to conceive naturally. And then it's having a very detailed and transparent conversation about what we know and what we might need to do to find out more. Sometimes that involves surgery. Myself, Mr. Colin Davis, the group director, we both perform surgery gynaecologically if it's required in London hospitals, and so that does allow those patients the ability to have continuity with their fertility doctor, but also gynecologists that are also doing the surgery, so they're not having to go somewhere else. So I think that's another real benefit of what the Evewell can offer. I think it's important to think about men and women separately in terms of what they can achieve. Because sperm takes 90 days to make a sort of new sperm, you can change the fuel that goes into the system of the man, perhaps, and change the outcome more easily. There's this sort of myth that you can't do anything about eggs, and I don't personally believe that. I think with good diet, nutrition, thinking about certain supplements, stress is a really interesting one for which you can't really measure it on a blood test. I can't really put it on a computer and say this is it. Interestingly, there was a small study done many years ago looking at hair samples in patients and saying that actually patients who are very stressed have worse outcomes. But you've got to think about that whole holistic situation, whether it's working with acupuncture, reflexologists. We really want the patient to come on a journey which results in high levels of success, but also try to make that patient, when they come into the Evewell, think about all those other things that they can be doing. And I think that empowers them to feel a bit more in control of what can feel like quite an out of control process.
I think control is really important for our patients because all of this feels very much out of their control. We've got some really good relationships with acupuncturists and holistic therapists. I think having been around the block as long as me and you have, it definitely odes to our benefit that we've got a lot of contacts in that have also been in the field a really long time that we've all got a deep respect for. So I think control is a really important one for our patients, and I think that's why, again, it comes back to the lab team being so involved with the patient, because that is definitely the part where patients feel they have lost all control. They hand over their, we call them gametes, eggs and sperm, and then the door is shut and nobody knows what's going on. And I think we do this really well. I think we're very open and honest and transparent about embryologists being part of your journey. So again, I have seen holistic therapies, nutritions turn patients' previous cycles at other clinics around into much different results once the advice is there. So I think that's a really important take-home fact.